Hello, everyone. Welcome to our second ever scientific Preemie Chat. Before we begin, I would like to acknowledge that Indigenous peoples are the traditional guardians of this land we call Canada, in which we gather here today for this discussion. The Canadian Premature Babies Foundation head office is situated on Treaty 13 territory, home of the Mississaugas of the Credit, Anishinaabe, Chippewa, and the Haudenosaunee and Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We recognize and deeply appreciate their historic connection to this place. We also recognize the contribution of Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community in particular, and our province and country as a whole. I am Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation, or CPBF, and I'm the mother of a surviving twin born at 26 weeks gestation. CPBF is a parent-led charitable organization that helps families in and after the NICU through education, support, and advocacy. If you are a family or a healthcare provider, please check our website, canadianpreemies.org. There you'll find resources and a community of people who want to see our little babies thrive. It is hard to believe, but we launched Preemie Chats 4 years ago during the COVID-19 pandemic to stay connected with our NICU community. Since then, Preemie Chat has become a reliable, engaging educational tool for healthcare providers and parents alike to talk about what matters, to explore new ideas, and to learn together. If this is your first scientific Preemie Chat, it works a little bit different than our regular Friday episodes. Today, we are bringing experts with different care practices to discuss a topic that does not have consensus in the medical community around the world. Today, we'll be navigating the controversies. We are talking about patent Ductus Arteriosus Management in infants born less than 28 weeks. Patent Ductus Arteriosus is also known as PDA. A PDA is a persistent opening between the two main blood vessels leaving the heart. This condition is common in preemies and can affect term babies. But for term babies, they often close on their own with no interventions. That can happen for babies born prematurely as well, but it's not always the case, especially for those babies who are born before 28 weeks who have lung disease. So, what do NICU teams do to treat this condition? As I said, there is no consensus. In fact, there are various approaches and many factors that must be considered before a treatment plan is created. Today, we are going to shed a light on the complexities of managing PDA in infants born less than 28 weeks. Is there strong evidence supporting one approach over another? What should be considered when choosing a strategy? How do family preferences play a role? Well, stay tuned. We have some lively discussions ahead, and I hope you will take a part of this as well. Please send your comments and questions as we delve into our topic. We will try to address them during our time together. So we are presenting this session today in collaboration with the Canadian Preterm Birth Network, CNN, the Canadian Neonatal Network, EPIC, the Evidence-Based Practice for Improving Quality, the Canadian Neonatal Follow-Up Network, Family Integrated Care, the Canadian Association of Neonatal Nurses, EFCNI, the European Foundation for the Care of Newborn Infants, and GLANCE, the Global Alliance for Newborn Care. We are thrilled to have a live audience for many countries around the world. And as I mentioned before, we want to hear from you. Let us know where you're joining us from. Please send your questions and insights in the comments below. We really want to hear from you what your units are doing to manage PDA in different parts of the world. So now I'm very honored to introduce our moderators for this session. So the first one, I'm going to bring him here, is joining us live from Montreal, Quebec, Dr. Gabriel Autit. He has a wealth of knowledge when it comes to premature babies and their hearts. He went to medical school at McGill University, after which he pursued training at McGill in echocardiography scanning He then did his postdoc research training in the pediatric echo laboratory at Stanford University. He joined the team at McGill University and Montreal Children's Hospital as a neonatologist in 2017. There, he created the new cardio lab. And then in 2020, he launched a neonatal hemodynamics clinical research fellowship at McGill, for which he's the program director. Dr. Gabriel Altitz, thank you so much for joining us here today.
Thank you for having me, Fabiana. It's an honor and privilege.
Well, we are very excited for this conversation, and I'm going to bring our second moderator, Leah Whitehead, joining us live from Halifax, Nova Scotia. Leah is the mother of Tessa, born premature at 28 weeks in 2013. After that experience, she returned to the IWK and ICU to build a peer support program that is focused on peer support in and after the NICU stay, but also aims to help volunteer parents and grandparents find some healing from the NICU experiences. Using a co-led model, she's developed a robust volunteer program that offers peer support that brings a family lens to the organizational policies and that engages and supports former NICU families. Leah, welcome, and I'm so grateful to have both of you as the moderators of this session.
Thank you, Fabiana. I'm excited to get into this topic today.
Well, thank you, and I think we'll jump right off into the midst of this topic, which we have amazing speakers today to have us share their experience and knowledge on this topic. And just to give some sense about the controversy, I think PDA has been studied for the past 40 to 50 years in the world of neonatology. And because of the complexity of how our babies evolve and the way we manage them, as well as the evolution of neonatology, we keep on asking the same question: is who is the baby? When should we treat the baby for a PDA? What's the role of the PDA? And I think today maybe we'll be able to get some sense from some of these experts in the field that will share their perspective, their experience, and answer some of your questions. And obviously, we'll look into some of the recent literature about some of the trials that have been done, but also some of the association that have been linked between PDA and some of the bad outcomes, and how can we try to mitigate them by potentially addressing this condition. So the first of our experts that are going to be joining today is Dr. Audrey Hebard. It's an honor to present her. She's a staff neonatologist and colleague at the Centre Hospitalier Universitaire de Québec, or CHU de Québec, in Quebec City. She did her fellowship in neonatology, followed by a fellowship in targeted neonatal echocardiography, as well as a master's. And so she's a clinician scientist and currently runs the neonatal hemodynamics program, as well as the targeted neonatal echo program at the CHU de Québec. Her research interest focuses on preterm infants with a special lens on what we call chronic pulmonary hypertension. Welcome, Audrey. Thank you so much for joining us today.
Thank you so much for having me. It's an honor.
And as Gabriel mentioned, we're happy to be joined by leading experts today. So I'm pleased to introduce Dr. Adrienne Bischoff. Dr. Bischoff is a clinical assistant professor and neonatal hemodynamic specialist at the University of Iowa Stead Family Children's Hospital. Her area of academic focus relates to the physiology following definitive PDA closure, neonatal hemodynamics, and the use of targeted neonatal echocardiography in different disease states that impact morbidity in preterm and critically ill neonates. She is one of the few neonatologists with accreditation as fellow by the American Society of Echocardiography, and she is also a member of the Pan American Hemodynamics Collaborative, or PAHC, and a council member of the Midwest Society for Pediatric Research. Welcome, Adrienne. Thank you for joining us today.
Thank you. It's also my pleasure to be here. So thanks for the invite.
Now, we do have a lot of ground to cover today, so we're going to jump right into the conversation and keep it moving. And I'm going to kind of kick us off with our first question. And I'd ask that when we ask questions, both of you can share your views, and that way we're getting kind of rounded responses. And then please, as well as been mentioned, put your questions and comments to our viewing audience in the chat, and then we can address those during this time as well. So I'd like to start by just saying, what is the approach of each of your units with this PDA management?
I can start. Our unit here at the University of Iowa is a more proactive approach in terms of the PDA. That's not to say that we are a unit that will treat indiscriminately any PDA or any baby that has a PDA, but we are a unit that has an approach that we are looking for it actively. We're looking for it early. We're looking for it in every patient. And we go based on a combination of factors, but most of them are echocardiographic factors. So if we do find a PDA in an extremely preterm infant that through echocardiographic parameters is deemed to be of significance, we are a unit that proactively will provide medical therapy and multiple courses of medical therapy if that's the case, and even definitive therapy for that PDA if it's persistent and continues to be echocardiographically a problem. That's important to say because we are in a slightly different mind shift from perhaps other places where they are still in an era where they go from, well, if it's not symptomatic, we're not going to do anything about it, versus if it is symptomatic, we might. We are more in a pre-symptomatic phase sometimes, where we believe that if you try to treat the shunt early enough and ahead of time, we may be able to prevent some complications and some other disturbances later on. So we are a symptomatic treatment place, but also a pre-symptomatic treatment based on echocardiographic parameters.
So we are, I think, more of the middle ground, as you will hear Gabriel speak it also. We are, I would say, like Adrian just described, more the symptomatic approach. So we don't screen for all patients, but we will screen, I would say, and our approach has been very much changing over time with the literature coming out. So this is kind of always evolving, but right now I would say that the extreme preterm infants, so we're talking like the tiny ones, 22, 23, 24 weekers. I think we're a bit more aggressive in kind of screening for these patients before they become symptomatic. But for the sort of older preemie, so we're talking more like the 26, 27 weeker, 28 weeker, for sure we will sort of wait for a patient to be symptomatic from the PDA in order to screen it. So I think it really depends on the population, but we will most likely wait for the symptoms to arrive. And then when they do have symptoms, we will do an echo, and then based on the echo parameters, so a bit like Adrian in Iowa, then we will decide if the patient does need treatment, and we do treat it if we find that the PDA is significant. So we do medical treatment, and then we can do more definitive treatment, either by cap closure or ligation, which was maybe prior to the cap closure, but it's still considered in some patients sometimes, very rarely, I would say.
Thanks for sharing. Maybe I'll just to complete the trio of the spectrum, I would say I'm at the other end probably. And for me, it's always inspiring to hear, like the experience and the perspective of others that are practicing or living the different areas of this world, because it just comes to show me that we always needs to stay humble about what are our convictions, right? Like I might be convinced about my approach, but then you go somewhere else and you see the recipe of the cake is still working well and the cake is pretty good. So it just tells you that I think that's the key, is probably consistency within your teams. Because it's when you get like so much variability that it becomes a bit more of a challenge to actually have something more coordinated. So what we do locally in terms of our consistent approach is that we actually don't actively try to accelerate the closure of the duct in our extreme preemies. We do monitor our patients. It's still something we keep in mind when we assess like comprehensively the patient at bedside. So we'll be aware if there is one. We will do sometimes echoes if we see that there are symptoms attributed to that condition, but we don't actively try to give medications to accelerate the closure because we're more worried about the side effect of the medication, and we're not convinced that actually it's worth whatever effects that are supposed to be of benefit. But again, it just outlines, I think, that controversy where we're each looking at the same studies and the same babies, and we probably have different approaches. And I'm sure we'll have the chance to discuss more about these different approaches as we go on, because we do follow our patients, and if they do end up, close to discharge or after discharge with still a remaining duct, then we do obviously consider going for like permanent closure with some of the more of the mechanical approaches, surgery or cath closure. But I think for me, just on this introduction, I can see that there's this whole spectrum, and I'd love to hear our presenters saying like, what's your current interpretation of the literature or of this controversy? Like, why do you think there's even a controversy in the first place that makes that there is variability within different units, like at least in different units? Hopefully within the unit, everyone is doing the same thing. But why do you think there's like this controversy about the duct? It seems to be like a passionate thing also. Like people are very passionate about it. Like, do you pray at the PDA church or do you don't pray at the PDA church? Would love to hear that.
I can start on this one. So I think it is a very passionate topic. I think probably one of the most passionate topic in the NICU, and everyone seems to be very certain about what they do in their NICU, that it's the right thing. And it's a really interesting question that you're asking, Gabriel. And I think looking at the literature, obviously, like you said in the introduction, like we've been studying the PDA for so long, but I think we need to understand also that like the patients that we're treating and neonatology has evolved so much, right? So when we're looking at maybe the literature that was done in the 90s or early 2000, we are now at a completely different, not completely, but like
it's not the same baby,
right? In the neonatology, it's evolved, and like the patient, the population that we're treating now is different than the ones that were definitely in the 90s in the literature. And even now, when we're looking at the literature, the current because we have like, I mean, just in the past year, 2 major RCTs that were published on the topic. And when we're looking at that, I think one of the main question that remain is, are we asking the right question? Do we have the right population, right? Because I don't think a 22-weeker is the same as a 28-weeker. You're talking about the medication. Are we even looking at the right medication? Like, do we have the right treatment, right? And there's more there's more literature that's going to come out, and maybe Adrian can talk to like the pivotal study later on, but like this is going to be really looking at a definitive closure of the PDA rather than treating it and having a PDA that remains open but maybe smaller. Like I think there's so many questions that remain, and I don't even know that we can define the PDA, right? Like I don't think we all agree what's a significant PDA. So there's so many questions and so much controversies that remain that I think make it difficult for, and obviously I think impossible to kind of all agree on how we interpret this literature.
Yeah, and maybe that's okay also, right? Like maybe it's good to have these controversies so we can push the science, right? Adrian, what do you think about that?
I was going to say that one of the problems that I see in the literature is trying to simplify a problem that is not simple. Everyone wants an easy answer. If I have a PDA with X, Y, Z characteristics, should I do it? Yes or no? Period. That would be easy. That would be a cookie cutter approach. We don't have to think about it. The trial said don't do it, then we're not going to do it. Or the trial said yes, do it, then we should do it. And it's so much more complicated than that, because within each patient, there's so much variability. Within each practices, there's so much variability. We have talked, of course, the three of us on the background many times about this, and how you guys treat even the respiratory aspect of your babies is so different from what we do here at Iowa, that on its own may change so much the course of what the PDAs are doing in Montreal versus what the PDAs would do if we use your approach here at Iowa, just because we have other practices that are so diverse. So I think part of the controversy is also that we cannot homogenize what we are doing with one aspect of a baby's care when all the other 300 aspects of the baby's care are so different between the different centers. And what I love about this is that even if you look at the highest performing places where they have the best outcomes, they are not doing the same things. They are sometimes doing completely opposite things, and the babies are still doing okay. So it means that it's not just that one answer. It's about what we do it globally about the patients and how we take care of them as a whole, and not just about that one particular aspect.
Yeah, it tells a lot about the resilience of these babies too, right? Like you can give a different, again, the recipe and the cooking, like you can give a different recipe and yet still like they'll still enjoy the cake. Like if I can put it that way. Leah, I think I cutted you again.
Yeah, no problem at all. I was just going to say that as a parent who sat on so many rounds, and I know on our team, there was always diversity in how anything was going to be treated. And I think as a parent, I appreciated hearing all of that discussion because it helped me also weigh it and give my perspective. So just wondering, for all of your centers, how do you bring the parents' perspective into this and weigh what they're thinking? And even how much do you translate all this? Because I do know there's like so many different pathways. Do you walk them through all the options? Do you walk them through the one you're most likely to use? How do you navigate that?
I would say that our approach is pretty standardized in terms of medical therapy, and we will always kind of present it in a way that, look, this is what we're going to do. And if the parent brings up a concern or is wanting to know a little bit more, then we will go into more details. The discussion will be a bit more in depth when it comes to more definitive therapies, or a more invasive procedure, like doing cath closure or surgical ligation. But for the most part, I would say, because it's so standardized, kind of what we're doing it as a unit and as a whole, we will always listen to parents' perspectives, but it's already kind of presented as like, this is what we do. These are our outcomes in our unit. And therefore, this is kind of the package of how we do our practices. Not to say that we would not be open if the parents had a different perspective, if that makes any sense.
Yep.
So we've this has been very interesting for me because we've been taking part in a research study. So the SMART PDA trial, which actually was coming from Halifax, led by Dr. Shovik Mitra, who's now in Vancouver. And this is really looking at the PDA treatment in the first week of life in the less than 26 weeker. And this has been very interesting for me because obviously we talk to parents before for the research, and parents need to consent to research. And it's been so interesting because it's either you're in the PDA treatment arm or you're in the PDA observation arm. And having the parents' perspective of some parents saying, oh, well, like I'm hesitant because we would really want the PDA to be treated. And then other parents being like, we're hesitant because we really want to be in the observation arm. So it's been really interesting. And I do usually, when I talk to parents about this research project, I actually take McGill as an example because I need to be very transparent that we're in the same province. If you deliver your baby in Quebec City, which is 2 hours from Montreal, you will most likely have your baby might have a PDA that is treated with medication or even more definitive. But if you are born in Montreal at McGill, then your PDA will most likely be observed, not all the time, but most of the time, right? And will not receive medication or definitive closure. And I think we need to be transparent with parents that right now we have different approaches we don't know which one is the best. And I think there's good in both. There are goods and bads in both approaches. And I think it's been very interesting for me as a physician to hear the parents' perspective and take that into account. And that's been possible with the research project. And I think I'm going to definitely bring that in more in the clinical, even when we're done that research project, because it's definitely been very interesting.
Yeah, that's super interesting. And I so agree. I think with you both, like exactly what you said, like the aspect of transparency, of sometimes outlining to families, because, families, first of all, we have the privilege to join their intimacy at a very, very difficult, challenging time of their life, right? So I see it as we outed them to really outline the kind of knowns and unknowns that we have in some of those areas that we're just not sure, and why we decided to take a certain route. So we were running also, which is interesting that Audrey brought it up. We ran actually a study where actually the center of Dr. Hébert participated, where we did echoes for more of the characterization of babies in the first few days of life, and trying to understand if their initial like cardiac signature would help us better understand these babies that are developing potentially more complex courses versus not. And when we were doing these echoes, I was always entering the room and with the kind of hat of saying, listen, like we're going to be doing this echo, and I might find something called a ductus arteriosus, which is a channel that is connecting two of the main vessels of the heart. And because of that, if you go on internet, you're going to start reading tons of things about it, and you're going to end up with like very conflicting information as a parent, which might bring a lot of, stress. Why is my child not going for surgery? Why is my child not going for, a little or like an intervention? Why is my child not getting certain medications like ibuprofen or Tylenol because of this condition? So I was always starting by saying, like, I might find this condition, and I just want to outline for you that if you go on internet, you're going to find all of this. And locally, we reviewed the literature, and we decided that in our approach, we would not give these treatments because we found that in our population, there was a good response of not giving the medication, and most of the babies closed it on their own. And our, overall outcomes when we look at the Canadian data is that we're a center where we're performing very well with our tiny babies. So I always start with that as a transparency. And I think that's very important to outline the transparency of saying, like, there are these different options. You're going to go on internet because you're very, educated people and you know how to use internet. I'm sure everyone Googles home as soon as they go home, like little things that we tell them, and you're going to read that there is this controversy, and we chose this approach, and we're not saying that this is the right approach. It's just the approach we decided to be the most consistent with. And I always try to also bring the perspective of saying, because we're all units that constantly look at what's happening elsewhere and constantly reviews what are the data and trials and studies and results coming from elsewhere, we always adjust ourselves. So it doesn't mean that we do something now like this. Maybe in 2 years, we're going to have a different approach because there's new data evolving and new data emerging telling us, well, maybe actually bringing them to permanent closure with a catheter might be better. And we don't have this information, but we're of course relying on some of these centers running these studies to provide some of that information. So we're like teams, and I'm sure all of these, the team of Dr. Eber, the team of Dr. Bishop are looking at the literature and how things are evolving and are actually participating to the literature. And so I would love to hear, if I can go on with the next question, is that knowing that science, and I know it's not a simple question, I know it's a very hard question, but knowing that science helps most of the time shape the way most units will practice by integrating this new data, what would you think would be the best study we could get? Like, what could you think could be the best way we could try to answer? Because you outline, I think, Adrian and Audrey, there's different also approach in terms of the timing, and do you wait for symptoms or no symptoms, and who do you select, the tiny ones or not the tiny ones? Do you select those that are only intubated because you're worried about the lungs, or those that are, growth restricted because that's a signal that's been more associated with intestinal issues? So I would love to hear if you have, you know, any ideas, because then I'm going to steal that idea and I'm going to do the research. I'm kidding. Any kind of sparks of idea that you can think of that could help drive at least some of the answers related? Maybe it could be part of the question, like, does interventional help? Does, the timing or things like that?
Well, first of all, you have to have the right population of interest. So what are the babies that are at highest risk for the PDA being a problem or causing issues eventually, however you want to define that. But let's say less than 26 weeks, okay, for whatever it's worth, just for the sake of an example. Then you have to choose an intervention that will actually take care of the problem. So if you give ibuprofen or Tylenol or whatever that is, and only half of the babies are actually going to close their PDA definitively and not reopen it again with that therapy, then that's not the right approach. So the ideal would be to use an intervention that definitively takes care of the problem. For example, cath closure, even though there's a whole other discussion because that's more invasive and there's its own risks associated with it. But in order to answer the question, is the PDA a problem? Yes or no? Should it be closed? Yes or no? That would be the ideal. And then you have to do it at a critical period of time. You can't just enroll babies having a PDA, which actually that's number 4. You have to define if the PDA is a problem. So they have to be standardization that the PDA is a problem for all of the babies that are included. And that we can go into the details of that. And that's a big discussion that I don't know if we're going to have time to get into it. But size and direction are not enough. So a PDA of 1.5 millimeters, which is what has been used as most of the trials, can be very different in a baby who is 22 weeks and who is 400 grams, and in a 28-weeker who is 1.2 kilograms.
And even the way we measure it,
1.5 millimeters left to right PDA is not enough as a criteria to define if the PDA is significant or not from an echocardiographic standpoint. And then going back to number 3, you have to use that intervention at a time where you believe that if you close it at a specific time, then you might be able to prevent other problems. So you can't enroll all of these babies and go through all of this trouble, but some of them you are closing at 7 days of life, and some of them you are closing at 60 days of life. So you have to choose some cutoff of when you're like, well, we've known from studies that if you have a PDA beyond 2-3 weeks of life, then you start getting into issues. Then you must perform that intervention before that period even happens, because then you start getting other confounders. So those are my preliminary thoughts. So almost impossible. Essentially, the answer is it's very hard to do it. But that would be, the idea.
The best case scenario, And Adrian, you alluded to the idea that even the definition sometimes, or the way we measure it, is a bit, controversial on its own, right? Like depending on the type of scoring, the technical aspect of who's doing the actual assessment, and how many of these assessments they've done. So I would love to hear, maybe Audrey and Adrian, you can share a bit of what are the things you tend to look at for at least selecting some of your patients for a therapy, because maybe some of the auditors might be wanting to know like what they should incorporate in their own practice if they do have protocols to treat the duct. Like what kind of elements you would look at, big picture, or references that you're willing to share with the audience?
So we, of course, we look at, so usually the symptoms will be the reason why we do the echo in most patients. So obviously if the team hears a murmur, low diastolic blood pressure usually, or even systolic, but usually more diastolic. So anyways, bounding pulses, blood in the one that we're trying to avoid, the pulmonary hemorrhage, obviously, is one of the big complications that we really try to do, usually the echo before that happens. And then we do the echo. And then the echo, what we look for is obviously is there a PDA or not. And I absolutely agree with everything Adrian just said. We do measure it. I think it's part of any PDA report. We do look at direction. You don't want to close a PDA that would be right to left and sign of pulmonary hypertension. That would be bad. So we do look at the shunt. But then again, and then it's important to try to see what's the impact of the PDA. So then we will look at the systemic impact of the PDA. So we'll look at the Doppler in the intestine, Doppler in the head, and make sure and see if there's an impact from the PDA. And then we will look at the pulmonary flow impact of the PDA. So sometimes you can have kind of overflow to the lungs because if that PDA is large and left to right, so then we will do measures, and I can go into specifics if the audience needs specific for the what are the measurements that we will do, but then we will do measurements to sort of assess pulmonary overflow and then the impact of that on the left heart, because then the blood comes back to the left heart, and then so the left heart can dilate and have to sort of deal with extra blood to the left side. So then we will do measurements in order to look at the impact on the left heart. So these are all sort of measurements. I think they're pretty standard. And then based on all of these measurements, then we will assess if we judge that this is hemodynamic PDA or not.
And Adrian, what would be any systems or scoring or references that you use locally in your institution?
We obviously train very similarly. So we use similar parameters for the echo. We have a local scoring system that we have been using and reporting that it's hard to validate. It's purely echocardiographic and using the same parameters that Audrey talked about. But the main reason to use the scoring is to have something kind of standardized, also to avoid some variation between practitioners, right? So that when we are talking to each other within our hemodynamics group, we know that what Adrian is saying, that it's a PDA that was considered moderate volume shunt, is similar to what my colleagues would have said the same. It's more so that we're comparing apples to apples and not just, well, I think this PDA has more markers. Well, but how many points did you get? Just so that we have a way of comparing with each other and also comparing the patients longitudinally, right? I gave a therapy, the PDA became smaller, but then all of the other markers are the same or even worse. So then I have a way to say, look, the PDA score actually got worse. So perhaps even though the size might have been slightly restricted, the flow through the duct is actually getting worse or at least not improving. So it's just a way of quantifying it a little bit better using this kind of multi-parametric approach. But there are other scores that are out there. One of the most famous ones is the ELCOFASH one that uses a combination of echo parameters as well as clinical parameters. And it's pretty good for use in the first 2 weeks of life. All of these scores have issues depending on, again, what type of population you're using. Probably does not perform the same way in a 22-weeker versus a 28-weeker. And it probably doesn't perform the same way in a 22-weeker day of life 1 versus a 22-weeker day of life 30. So you always have to take it kind of like with a grain of salt. But having said there is some value to it, because as long as you are practicing in a standardized way, like at Iowa, we are treating these PDAs relatively early. So the score is probably still okay for the majority of the patients that we are using it for, because we are using it for 22 to 26 weekers in the first 2 to 3 weeks of life. So the score is probably still reasonable and standardized at that age. Once we get later on, then we have to think, well, this could be a fact of this could be a measure of the baby being older or the PDA being there for a long time, and then we just have to analyze it individually. But there are ways of trying to, quantify to some extent.
Totally, and I've put and I'm sure these links will be showcased, but some of the publication that your group has already outlined in the literature of some of the scoring systems that have been used, at least in your practice, and on which you've very transparently outlined for the scientific community for the approach that you've been using in your tiniest babies. So, and that's very useful, because then we have opportunities to translate that in our own practice and revalidate certain scoring. So if people on the line are actually using echo in their particular assessments, I definitely encourage you to go and look at some of these papers that may help you better standardize the way you assess these patients, knowing that there are these caveats of obviously changing physiology throughout the time and at the different range of immaturity. And I think going back to the parental perspective, I was wondering, Leah, I think you're one of our parent representative. What would have been like some of the question, like let's say you were told like in the NICU, oh, we're going to be treating a duct, or we're going to be giving medications. What are like the first few kind of, I guess, thoughts that a parent may have at the bedside? And if you can take it upon this and maybe expand, what are our experts doing for families regarding these particular questions that some parents may have?
Yeah, I think it's so interesting. Audrey, you brought up that SMART research that Shovik was doing. I was a part of that here in Halifax. And transparency from the parent's point of view is he walked me through all the steps, all the education, all the different pathways, and asked me as a parent, what would I do? And I gave him a response. And then months later, got walked through the same process and was asked, what would you do? And I chose a different answer. And so I don't know if that's like emotional state of the parent even, or, all the different factors that go into our decision making. But as a family, we always valued the least amount of intervention. And so anytime the neos would come to the bedside and would have an idea of something they wanted to do, I would try to get as long of a timeline as we could. I would always do the pushback of like, well, could we wait another 24 hours and see where we're at? Could we do this? Could we? And part of that for us was just, first of all, processing the information, but also then really looking at, okay, we're not a family that medicates everything. That was kind of our values through the pregnancy, through delivery, and through our lives and our children's lives. We never want to kind of jump on something. At the same time, I had different neonatologists who I really trusted. And I think the value of the trusted voice, building that trusted relationship, makes a huge difference. And so even as Shovik was walking me through the steps, at the end of it, I said, what would you do? Because he didn't share that. He was totally like unbiased as he was sharing it. I know he had an opinion, but he wasn't swaying me either way. He was just presenting the information. And the other thing I appreciated was him saying, we have strong evidence toward this. We have weak evidence. Because I also felt like, it's true. We don't have the answers. We don't know the best pathway. I do think everyone's goal is to do the best possible for these babies. But I like to hear, we have strong evidence to lead us this way. Then it's okay. And when it's the weaker evidence, then I feel like more of myself comes into that decision. Because if you have weak evidence and you don't know, then I can bring more of our, family perspective, family culture into the decision that's being made. Because if we don't know, then we don't know. So that's kind of how we navigated all of our major decisions in NICU. I think every family has a different strategy, but for me, it was very much, how can we still honor who we are as a family and still be safe, still treat everything that needs to be treated in a way that'll give us the best possible outcomes.
That's super important, because I feel you translate a lot of the realities of our families that often we'll sit down with us and we'll sit down with them and we start discussing, and then there's areas of gaps, and having the input of what they have as a family perspective brings in so much to these discussions. And also, as you outline, one decision one day may not be the same as the decision the next
Right.
day. And there's processes also that comes into place about reflection and trying to understand and the evolution of things that may also modulate the way you're going to be deciding as a family or parent at the bedside, or even healthcare practitioner on the other side. And thankfully, we work as teams, right? Like I see that the
Mhm.
NICU work is a lot. It's just not like a one person show. It's often like a team where the parents are there, but also all the other allied healthcare professionals. And it's not just me when I'm the doctor taking care of the family and the baby, but it's like all my other colleagues and all like my colleagues in cardiac surgery or cardiac interventional or cardiology. And I'm
Mhm.
sure it's kind of seen similarly in some of the other centers. And I was wondering if Audrey and Adrian could share also like maybe the process for at least some of these patients that you maybe consider borderline in some of your centers. Like you're not sure if you should or not. Like how do you guys approach that as a team? Do you bring it as a group? Do you have a discussion with the families? Do you bring it with your surgeon or your an intensive care doctor, an interventional care doctor? Like, what's the approach when there's more of these like unclear population of patients or patients who may have like risk profiles, let's say?
I think you just said it. The word is team, right? So we don't. I will never make a decision on my own. I am the hemodynamic consultant, so there's two of us in Quebec City. So when we have a patient that we're sort of gray zone, unsure, not responding, not behaving like we expected, because that happens a lot with our patients. We then discuss it as a team, right? So usually my colleague who also does hemodynamics will talk about it. We'll bring in the team, the treating team. So the neo who's responsible for the patient. And we will discuss it. We will try to involve parents. I'm not saying, well, we try. It's not that we don't involve them. We do, but I find that when we're in that gray zone and as a team we're hesitating, the parents will usually, when we discuss, will be again transparent about the hesitation. But I think like Leah just brought it up so beautiful. It was perfect. It was beautiful how you said it, and I think I will never be able to speak like that as how the parents are feeling and interpreting. But I think it's difficult when the team is hesitating to put that decision on the parents, being like, we're not sure on what we're doing, what we should be doing. And I think when the parents bring their family values, it can help the discussion, and it needs to be taken into account. And then as a team, we try to make the best decision for that patient at a time. But it's definitely not a one-person show. And we always try to kind of individualize care for that patient.
Mm.
Yeah, I agree. We are also a team of consultants. So for the tough ones, we always discuss it together and bring it back to who the primary doctor is. And then you weigh the pros and cons and you lay it all out on the table. If we treat it, it may not work. And then we might end up on this situation, and then what we will do next. If we do this, then we might have to, hold off on feeds. Then there's the risks of that. Are we willing to do that? Yes or no? And kind of just talk it through all of the nuances of the care, and then come up with a plan. And then I agree with Audrey. Usually we try to kind of present transparently to the family. Look, we don't know that this is the right approach, but as a team, we've discussed, and our recommendation would be to do X, Y, or Z. What do you think? Do you have any concerns? Do you have anything that you would like to weigh in? That's kind of how we present it. because I agree that it's not fair to say, well, we don't know, so what do you want us to do? It's like, well, that's not really fair. Like, you are the doctors, you know the science better than us. I appreciate you asking your opinion, but how come you're asking me to make that decision, right? So we usually try to present it already like, we would probably recommend this, knowing that it may or may not work, that it may or may not be right. Are you okay with that plan? That's kind of our usual approach, I would say, for the gray zones.
And I think it's such a, I think I'm still learning, and I love having this discussion and having a parent here, because I think it's such a fine line when we're talking about PDA, but there's so many things in unitology that you're kind of in that gray zone, right? And you don't want to put the decision on the parents, because that's not fair. But at the same time, you want to be transparent that we don't know what the right answer is. And I think this is, to me, like, this is still where I need to learn and grow as a physician of having the parents part of that discussion, but without putting the sort of the
burden.
Yeah, the burden and the hesitation of decision, and that feel that the parent needs to make a decision, because that's I don't think that's fair to the parents. So anyways, I kind of want to hear what Leah thinks about that when there's a gray zone.
I think the balance that you're all talking about is so important. And so that's what I'm hearing is, yes, you want the family input. We don't want to put that on them. At the same time, that transparency. And so I know I would kind of bounce ideas off the team when we did rounds and would kind of say, like, what do you think about this? And again, it's that trusted voice that I was listening for, that certain team members, I'd be like, oh yeah, I kind of align more with them. And the discussion part, like, I so appreciate when the team would have a discussion in front of us. And so it wasn't like, okay, we're going to go away as a team, we're going to talk about it, and then, we'll let them know what our plan is. But instead saying, like, we don't know, here's some of the discussion we're having. And even if, and there were oftentimes I didn't understand it all, my background's not medical, I still would kind of go, okay, I can hear what they're saying. That kind of makes sense to me. And then it's kind of that serve and return, that we're not putting the burden on the parent, but if they say, like, this is where I'm leaning, and then it's being the big hands and supporting that decision and going, yeah, okay, that it's almost affirming that decision that none of us know. Let's try it. Let's see where this path leads in that gray zone. And the other part of this, and this has to do with transparency as well, is that life after NICU. So we do know that there are some long-term effects, treatments, outcomes that come out of any decision we make in NICU. And I think sometimes the focus is so on the discharge. That's kind of the big plan of getting baby home. And there are times when the long-term effects aren't considered or weighed, at least as openly, perhaps, as the talk of the treatment plan. So just wondering how you address these long-term outcomes that are aligned with certain treatments or management of the PDA. Do you go over those with families? What kind of follow-up is done after the fact in each of your units on this?
So we do try to bring it up, especially when we're not, we're again in that gray zone. I think there still needs to be a lot of research on sort of the long-term effect, right? Because we're, again, back to the literature of not having all the answers, because the population needs to be defined. The disease, like what's a significant PDA, still I think needs to be well studied. And I do, and this kind of lies in with my interest, my research interest, and Gabriel's research interest of sort of the long-term impact on like the pulmonary hypertension, right, in these patients.
Mm-hmm.
And I think that's important to bring up when we're talking about PDA and treatment, and especially if observation versus treatment or more definitive treatment, right? So I do try to bring that up, but I think we still have so many questions that are unanswered about the long-term impact of all of this. And even now, the newer, like we were talking about cat closure, right? So cat closure is fairly new, and we do have data for patients that have this maybe in the past few years, but we don't have the data in 10, 15, 20 years
Right.
for those procedure, because I mean the patients are just not there yet. And I think that's I think we also need to tell the parents that, right, when we're talking about the procedure. I think that is a question mark that we just don't have the answer yet, and that's important to, I think, bring into the discussion, whether we decide to observe, treat, or go into like a more invasive procedure.
Yeah, and just to add to that, one of the problems with long-term outcomes is if at the short term there's already so much heterogeneity and so many things that play into a short-term outcome. Let's just say, should we treat the PDA as a goal to get the baby out of the breathing tube? There's so many other things that play into that decision of getting the baby out of the breathing tube. In the long-term outcomes, that's even more complicated because the amount of factors that go into what will cause BPD, what will cause need to go home on oxygen, what will cause feeding challenges, what will cause, whatever, neurodevelopmental issues. There's just so much that will add on to that it's really hard, even harder in the long term, to pinpoint a single decision that you made, which was give ibuprofen or not give ibuprofen to a PDA on day of life 14. It's really hard to say that whatever outcome might have been related to that or not.
Right.
In the short term and even more in the long term. So that's a challenge, but I agree with Audrey. We try to address it. We know from some studies, including Audrey's and Gabriel's together, that there's some evidence about the effects of prolonged shunt exposure or non-treatments and whatnot on some other diseases that we can try to bring it up. Acknowledging, again, bringing up transparency, that it's not a single factor that plays into those type of outcomes.
Yeah, totally. I so agree. I think there's a richness to the babies and family that we care for, and they keep on teaching us lessons about what we believe is the truth, and then we realize that we were completely wrong. But what I think is incredible is to actually see how much of our babies are really growing in the community once they're discharged into incredible people, like full of that richness of lifestyle and values. And so no matter the type of recipe that we use in the NICU, it does seem quite consistent across pretty much every cohorts that have been published, that one of the main driver of these long-term outcomes is actually kind of the love and support and environment that the family is giving to these babies. And so that's what I always tell some of my families I meet in the NICU, is that the best medicine is actually the type that you give and not what I give. So, no, but it's true, right? It's a lot about.
It is 100%.
It's like invest in breast milk, invest in parental presence by helping them coming to the bedside because they have three other kids at home and they live far, and try to find solutions for that, and invest in supporting them in the community, and probably all of these outcomes will go skyrocket, like improved, right? And so I do think though that we try, at least on that flip coin side, as neonatologists and healthcare practitioner at the bedside, to at least perfect the most that we can the support that we can give medically. But I think the long term is like so much driven by all of these other factors. So you can choose a bit of the salt and a bit of the sugar you're going to put in the recipe, but if you don't have the good pan, and if you don't you need that thing to support the entire thing. And I think the family is that big medicine for some of these babies for the long term outcomes. Like a lot of it is driven by that. But I
And
do agree that it's important to see some of these studies that are ongoing for specifically trying to answer some of the narrower questions about, the cath closure, for example, like what's the effect of that, or the approach in the pre-symptomatic or symptomatic stage, what's the effect of that, and trying to see if there are like signals in the long term. But I still believe that it's the family that's the biggest driver of that. Audrey, sorry I cutted you.
no. I mean, I couldn't agree more with what you were saying. And I think the other portion that is important is that in the research, like we need to know what are the long-term outcomes that are important to the family, right? Because
Yes.
Totally.
we keep that BPD, right? Like BPD has been in every single outcome, I think, of every PDA paper out there. And like, do parents really care about PDA? Like PDA, but BPD, right? Like,
They don't care about the PDA. They don't
I don't
care
know if
about
they
the
care about
BPD.
PDA. I
All
hope
these
so.
three
Like, we've been
letters.
talking about it for an hour, but the BPD, right? Like, do they even care? Like at 36 weeks, like if the patient is in room air or like on of course,
Right.
the baby to extubated and stuff, but probably that's not what's so important to the parents, right? The parents, like, and I think the voices to the parents, like, we need to know. And I think as a scientific community, we need to be more aware of that, of having parents in our research and asking them what matters, like what's the long-term outcome that we need to be studying,
Mhm.
and knowing that a lot of what we do in the NICU probably won't have that much of an effect in the long term. Like, and I think it's not one thing, it's a combination of many
Yeah.
things. But I think knowing what the long-term outcomes are, and what's important to parents and what matters, I think we still have a long way to go, especially in the PDA literature, on that.
Yeah. I love also, and that relates to what Adrian was saying at the beginning, how sometimes in medicine we like to be simple and binary of like, yes or no, there's a PDA, and yes or no, there's like oxygen, or yes or no, there's BPD. And the life story of a kid and his family is so much more complex and
Mhm.
rich than that, and the
Mhm.
perspectives of them are also completely different, right? Like what is meaningful and what is important for someone may be completely different than your neighbor. And
Yeah.
of course, I think as we're evolving and doing, I guess, research that's going to be more impactful for families and for healthcare professional, it's to take into account what you just mentioned, Audrey. It's like this perspective and the richness of this perspective, right? Like what we're trying to measure is simplified because I guess that's what we've been primed up to this years to be measuring. But at the end of the day, we all know that probably there's so much more happening, and probably much more to be able to evaluate rather than just like a one-time point, a one element. And when we're introducing treatments or management, it's such much more of a spectrum and continuum, and it's never that white and black. It's always like that gray or even that rainbow color. Right? It's like completely more complex than this simplified approach. Any other maybe Adrian or Audrey, any questions from your part from, I guess towards the audience? I know we have only a few minutes left, so I want to let the stage open for everyone to comment or question or bring subjects that you may have behind your mind.
Well, I think we can just keep going a little bit more on this topic. I can ask Leah because she's here with us and it's easy. What are some of the, when you asked the long-term effects question, what did you care about as a parent? What would you like us who are doing the research to start focusing a little bit more? And we can start about PDA. What type of effects related to the PDA or the therapies of PDA that you think would be worthwhile and that we should be exploring more?
Mm-hmm. Well, I know out there in the world, there's a study on coming out of the follow-up clinics. I think it's CN Fund that's putting that out, that's looking at families' preferences in terms of outcomes and what values they have, and also how they want even that determination to go in terms of like when a child is being assessed, what are we looking at, and what's important to family versus what's important to the healthcare providers, which is typically the way it's gone up until this point in time in history. But I think for me, it's a very personal question, but in NICU, many times my husband and I would say, we want Tessa above all else to be happy. And what does that look like? I mean, we as a family, we could face challenges that come. But for us, we wanted her to know without a doubt that she's loved, that she's valued, and that she was happy. And so for us, that determined our path in NICU, because I sacrificed a lot to be there with her. I did the pumping and the, all the, which is hard work on top of the emotional space you have to make. And so for me personally, it was very much, I didn't have emotional space for anyone else because it all went to Tessa. So I wasn't at my best self. I know that with the team, I wasn't at my best self with friends or family, because it was all going into her. And partly because I so closely align with what you were saying, Gabriel, that it's that love, we don't know what that does. We do know that it has, I would say immeasurable results, but we don't know what exactly. And so when I look at the outcomes, I mean, I have an asthmatic child now who is followed as a result of her prematurity by the lung clinic. And that, to me, on the grand scheme of things, is easy. And, that's for me personally. So I hesitate to put that out. Other people may have other opinions, and please feel free to share it. But for our family, it was like, if this is the result of the outcome, I can live with that. And when we looked at them, it was always, what is her life going to look like in terms of her happiness? And that, I think, is the outcome we're going for. And when you have families who know how to advocate with their kids because they've experienced NICU, then I think you're almost set up differently. Tessa was our first kid, and I always say that she changed how we parent. It didn't just change our family composition, but changed how we parent. You learn how to advocate. You learn how to speak at appointments, at schools. And it also made us, frankly, more laid back, I think, because when you see your child fight for their life, then everything else is kind of like, oh, you're fine, you're good, you fell, you bonked your head, you're good, get up. So I think, that's a hard question, and I think it's a very personal question, but I think it's definitely one we need to be asking our families when we are bringing them in on these discussions and decisions of what's important to your family and what do you want your future to look like.
Thanks for sharing. That was beautiful. And for us as physicians, it's very humbling to hear and to remind ourselves that that's what we're striving for. That's what we're doing. It's very easy for us to get into the mindset of being objective and scientific, but this is why we do what we do. So I appreciate you sharing it.
Yeah, definitely. This perspective is so important. And we're actually trying also locally to have a lot of our parents come back and tell us like what to measure and what to evaluate, and is this research meaningful for you, and is it worthwhile investing all of these resources that we think is going to be important to invest to study a certain question, if in the end for the family it's not that meaningful and important. So I think it is important to include like parent partners in some of the projects, whether it is interventions you're implementing in your unit that you hope is going to help alleviate some of the stress or some of the burden during the course of the hospitalization, or even after the fact in the community. So yeah, thanks for sharing, Leah, this piece of advice to all of us that are doing some research in this space of prematurity. I think it's quite important. I wanted, it's, I think, almost time to say goodbye. And before we do, I'd love to give also some time maybe to some of our experts here on the line to give us the final thoughts or takeaway message from this whole session that we had today. So Audrey, maybe you can start with what are your final thoughts and takeaway message for the audience?
It's really difficult to go after what we just heard, because I think it was beautiful, and it was just like I was listening and just wow, like amazed how Tessa is very lucky to be in such a loving family. But yeah, sorry, I stopped being a doctor for a while, and I was just listening. So yeah, I think this is one of my takeaway. I think we need to keep involving parents. I think parents needs to be part of our discussions. I think the PDA, this was a really interesting discussion. I've discussed the PDA many times with Gabriel and Adrian, and every time it's always very interesting and fascinating. And there's I hope that the audience can. There's so much respect. I have so much respect for my colleagues, and even though we do things differently a little bit, I think Gabriel said it earlier. I mean, the outcomes are mostly similar between centers, and even though we don't agree, we don't always agree, we do things a bit differently, in the end, like the patient is always at the center of every decision that we make. And I think we all hope that we're making the right decision for each individual patient. And takeaway again, I think the family is definitely a big part of every success that the team has in the NICU.
My takeaway is that this is what I live for. This is why I do what I do. I love the discussions. I love keeping myself motivated to always try to do the best that we can do. Can only do your best until you know better, and then you do even better, right? So I learn from my colleagues also every day and their approaches, and I try to keep an open mind. And we can have always open and interesting discussions scientifically, but it's always enriching. I don't take it personally. For me, this is why we do what we do, so that we always have the same common goal, which is to make our babies better and make our families better. So this was fantastic, and I appreciate the opportunity to be here today. I hope this was helpful for the audience.
Leah, your takeaway maybe? Would love to hear.
I think you've all said it. It's always interesting to hear the different sides, for sure, and that it is a collaborative team, both healthcare team and families. And when that team comes together, then magic happens in NICU. So thank you, everybody, for sharing your thoughts today.
Yeah, what I wrote on my little booklet is keep an open mind, keep that transparency, and keep that parental and family involvement. And I think if we keep these kind of three for everything that we address in NICU, we're always going to be providing comprehensive care for our babies, and an open-minded care, which is very important, knowing that our families are going through challenging times at times, and good times also, hopefully, like moments of joy. So really a pleasure to be part of this panel, and a pleasure to hear from our experts and from our parent partner, Leah. It was great. Adrian, Audrey, thank you so much. I think I'll ask Fabiana to join back so we can wrap up the session today and end the discussion and share some of your last thoughts. Thank you.
Wow, thank you all of you for joining us here today for such a great discussion. I also had my own takeaways, and I love the discussion about family involvement and outcomes. So I echo Leah's words for sure on that. And yes, the Canadian Neonatal Follow-Up Network has the Parent Voice Project, asking parents what are meaningful outcomes to them, and bring us to your research. We also want to help you to ask those questions on the research, help you to shape research so we can advance care together. So thank you, all of you, our amazing panelists, for being here with us today. Dr. Adrian Bischoff just had a baby, so I'm very grateful that she took the time to be here with us today. And Dr. Audrey Hebert, thank you so much for being also our guest today and add so much to this conversation. So I hope I see you both again very soon. And Leah and Gabriel, thank you so much for moderating this panel. It was such a great discussion, always so much to learn and really find ways for us to work together as parents and scientists. So thank you for taking the time out of your busy schedules today for being here. Thank
you so much for having us.
And to all of you watching us live, thank you so much for being with us today. This is a very important platform for us to discuss care, to discuss how we're going to advance care together. And the more we can learn from each other and exchange ideas, data, and practice from around the world, the more our NICU families can have better care experiences. It's been a privilege to host the Scientific Preemie Chat as we work together. It takes many voices and many hands, and you have all certainly contributed to that today. So thank you. We will have another Scientific Preemie Chat in June on another hot neonatal topic. So keep your eyes and ears open, so we can inform you where our next topic and the date. So if you also have any idea for a future topic, please reach out to us and let us know what you can bring to you. And if you miss part of today's debate, please head to our YouTube channel or our website, which is right here, thecanadianpreemies.org, to see the full episode. And you also find a tremendous library with more than 300 episodes on various topics recorded there. And as I mentioned earlier, CPBF is a charitable organization. And so I ask you to consider how you can support CPBF in its mission to empower families of premature babies every step of their journey. So together we can create a brighter future for all preemies and their families. So join us Friday on our regularly scheduled Preemie Chat. We're going live at 1 o'clock Eastern Time. And this coming Friday, we'll be talking about the importance of telling and sharing your story. And we'll talk about digital storytelling to foster healing and resilience. Don't miss it. In the meantime, be well, everyone, and thank you again.